All right, we're going to talk about Chapter 9, Airway Management. The topics we're going to talk about is airway psychology, airway pathophysiology, opening an airway. We're going to talk about obstructed airways, airway adjuncts, suctioning, and I'm going to teach you how to keep an airway open. And we're going to talk about special considerations, airway psychology. Right? Airway is divided into two parts, the upper and lower. The upper begins at the mouth and nose. Behind the mouth and nose, it goes into the pharynx, which is in the posterior, the back, and lower part of the mouth and nose. We got an oropharynx, which is behind the tongue, and a nasal pharynx, which is comes off of the nose, right? And the laryngeal pharynx is the lower portion, right above the larynx. And the larynx is the boundary between the upper and lower. That's the dividing line. Above the larynx is upper airway, of course, and below the larynx is lower. Here's a nice picture showing you all of the different pharynxes and where they start and stop. Lower airway. We have the trachea that lies below the pharynx. That's our airway, or our tube where the air moves from the upper airway through the lower, right? The trachea is made up of 16 cartilage rings. The top one, the very top ring, next to the vocal cords, is completely encompassed, or all the way around. And all the rest of them are only about 3/4 way around. What these do is they add rigidity to the trachea so it doesn't collapse on itself when you inhale or exhale. From the trachea, it'll go into the main stem bronchi, which branches from the trachea and progresses to smaller into bronchioles, and eventually end up in the alveoli, which is the air sacs at the very end. Remember that pulmonary capillaries surround these alveoli, and the thin membranes let oxygen and carbon dioxide exchange across these membranes or through the diffusion process, where we go from a higher concentration to a lower. Here's a picture we've seen several times. This is the brachial tree, showing how the trachea comes down, it splits at the carina, and it divides into the right and left main stem bronchi. They get smaller and smaller, branches out like trees until it ends up in the alveoli. Here is those bronchioles, which is the smallest part of the bronchi, and then they end up with the alveoli, or the air sacs. Pediatric airway physiology. Airway structures in infant children are smaller, narrow, and less rigid than adults, right? We've talked about this several times. They can be easily obstructed, their mouth and nose. The tongue is proportionally larger, which is a big issue as far as obstruction when they lose tone for some reason or become altered. Young children, newborns and infants, they're predominantly nose breathers. This can cause an issue when they have congestion and they have trouble breathing. Remember, the tracheas are going to be more flexible, they're going to be narrower, softer, and can be easily obstructed by swelling and foreign objects. And we think of foreign objects as like something a child put in their mouth, but it could be blood from a trauma or excessive secretion from an infection or swelling. Their chest walls are also softer. They depend on their diaphragm more for breathing, or we refer to them as belly breathers. Instead of using intercostal muscles and other muscles to help breathe, they depend on the diaphragm a lot. Here's a picture that compares the adult and child airway passages, and you can see the differences in there and the size, how much smaller the actual airway is, and how much larger the tongue is on a child proportional to an adult. Airway pathophysiology. All right, we're going to talk about airway path. A variety of obstructions can interfere with breathing, right? We have foreign bodies, which could be like small toys, foods, all kinds of things. liquids, including blood and vomit, and excessive secretion as well. Loss of muscle tone. So if for some reason they would go unresponsive due to trauma or illness or whatever, they lose muscle tone. The tongue will actually slide backwards, and the epiglottis, that leaf-like structure that closes the epiglottic open when you breathe, it is actually attached to the tongue. So when the tongue slides back, this epiglottis will actually close the glottic opening and become an obstruction. When we talk about obstructions, they can be acute, which means all of a sudden, without warning, or they can be chronic issues, like, for example, asthma or chronic croup or chronic diseases that a child could have or an adult. And you have to constantly check. You have to initially evaluate the airway, and then you're going to monitor it for patency over time. So it's not, we don't check our airway. We got an airway. We move on. We'll continue to monitor this airway. Severe allergic reaction or anaphylaxis causes rapid airway swelling, right? So this is an issue. It'll cause your swelling to the point that it's obstructed. Other things that can cause airway obstructions are burns. Burn patients, especially people that are in house fires and all that superheated gas they breathe in, that can cause swelling in the airway. Blunt force trauma, infections, these all can cause swelling of the glottic opening area. The smooth muscles in the bronchi can change the diameter of the bronchi and create resistance. It's just like we talked about in blood vessels, how the smooth muscle will contract and make it smaller. Same way with the bronchi, they can contract and make it smaller, or they can dilate and make them larger. Sounds of a partially obstructed airway. We have 4 different sounds. We got stridor, hoarseness, snoring, and gurgling. Stridor is a very high-pitched, almost whistling sound. This indicates a narrowing of the airway passage. It can be severely narrow due to swelling, an obstruction, whatever. It's in the upper airway. Hoarseness is raspy, change in the voice, especially acute. That could be swelling around the vocal cords. This we see a lot could see in house fires when we have a victim in a house, trapped in a house. Snoring. It's similar to the snore during sleep and indicates diminished muscle tone. It means your tongue is sliding back, and then that epiglottis is sliding over that glottic opening. Gurgling sound is what? It indicates vomit, blood, or secretion in the airway. A gurgling or bubbling, right? So that means water in the airway of some sort or liquid. We got to ask ourselves, is the airway patent? There's 2 questions. Is it open, and will it stay open, right? And if your patient's talking, that means the patient's capable of moving air, right? So if you've got a patient that's actually talking, they're moving air. Stridor can be present in either inhalation, exhalation, or both, right? And this is an ominous sign if they have stridor on any of these, but especially if when you breathe in and out, you have this high pitched whistling sound. So when a human breathes, we shouldn't be able to hear sound, right? Normally. If they're sleeping, yes, it could be a snoring, which is muscle tone or whatever. But an adult human being, we shouldn't be able to hear. We definitely want to be hearing a gurgling, gasping, crowing, wheezing, or snoring, right? Sometimes you'll show up to scene and the patient uses body position to keep their airway open. One that I can think of is the COPD, and they'll go on that tripod position, which we'll talk about later when we talk about respiratory emergencies. When we're assessing the airway, it's in our primary assessment. Again, we'll talk about during our assessment chapters. And if we find a problem, we're going to stop and fix it at this point. We don't go any further until we fix that problem. Again, it's not just a one and done thing. It's a constant consideration. That's especially true in critical patients. You may need to consider how to keep an airway open immediately after establishing it. So you may have to figure out, how am I going to keep this open? And if you have a partially obstructed airway, you must be considering, how long is this going to be before it turns into a total obstruction or complete obstructed airway. The ability to maintain airway can change over time, right? Mental status affects the ability to maintain airway. So they could be have a partially obstructed airway, their brain's not getting enough oxygen, they go hypoxic, they'll end up getting altered mental status, start losing muscle tone, and again, that tongue could relax and the epiglottis slide over and cover the glottic opening. And there's no guarantee that an airway will open or remain open. Signs of inadequate airway: no signs of breathing or air movement, definitely. Evidence of a foreign body in the airway, like we see vomit or blood coming out of the mouth or whatever, secretion. We don't hear or feel any air moving over the nose and mouth. If they have or the inability to speak, suddenly have the inability to speak or difficulty speaking, especially while eating. Unusual hoarse or raspy quality of the voice. Again, an acute thing following a trauma or ailment. Absent, minimal, or even uneven chest movement. This is definitely a sign of an inadequate airway. Breathing movements limited to the abdomen if they're just belly breathing only. Diminished or absent breath sounds. We'll talk about that later. Abnormal noises such as the wheezing, the crowing, stridor, gargling, gasping, all those. Like I said, you should not hear someone breathing. In children, retraction above the clavicles in between or below the ribs. This is called using accessory muscles to breathe. When you see the muscles above the clavicle, which is that collarbone, or when you see those muscles in the rib kind of sink in, this means that child's really working hard to breathe. Or if you see nasal flaring, especially in children and infants, that's a definite sign of inadequate airway. They're trying to make more surface area to bring in more oxygen. Okay, so let's talk about how we're going to open an airway. Again, airway problems must be dealt right away when we find them. We don't move on after we find it. We have to fix it. We're going to open and maintain an airway on any patient who can't do it for himself. For example, an unresponsive patient. If they have a diminished mental status, we should lay them prone. We can better manipulate the airway from the prone position. If we suspect a spinal trauma, like they fall off a ladder, a car wreck, whatever, hitting the head with a ball bat, we're going to protect the head and neck. However, airway has priority over spinal protection. What do I mean by that? If I've got to manipulate the head or neck to open an airway with a patient who's not breathing, we're going to do that over not doing it and protecting the spinal column or C-spine protection. If time does not allow for complete spinal precautions, which means C-collar, backboard, blah, 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 we're going to provide manual inline stabilization. It's where we hold their head, right? Some indications of head, neck, and spinal injury in unconscious patients. The mechanism of injury that caused such injuries, like we talked about, falling off a ladder, head first, a car wreck, diving accidents, all sorts of things, blunt trauma to the head or neck. Any injury that is at or above the shoulder, we're going to consider head, neck, and back injuries. And we're going to ask families bystanders. Maybe they can indicate what happened. We can conclude what kind of injuries could come from that. Some patients will have an open but threatened airway. We should put a conscious patient in a comfortable position. And unconscious patients should be placed with a head elevated sniffing position. We're going to talk about that here in the next slide. Here it is, the head elevated sniffing position. It's a slight elevation and interior positioning of the head, which aligns the airway structures for improved pacing. So we're aligning that airway. You're going to be moving the head interior as if they were sniffing flowers, if you ever sniffed a flower. If supine, this you may have to put padding behind the head to get this into this position. Anatomy and head size can create unique positioning needs. In pediatric patients, we have to actually pad the shoulders since their head is so big, bring their shoulders up to get that airway in line. The optimal position is achieved when the patient's ears are at the same level as that suprasternal notch. Super means above, so just right above that sternal notch. And if we worried about spinal injuries, this may be contraindicated, right? So if we have time, we're going to do manual stabilization, stabilize it as we're doing the airway. Providing an airway, manual maneuvers. If the patient don't have an attacked airway, we're going to have to open it, right? And ongoing interventions. These airway obstructions sometimes are often caused by diminished control of muscles in the airway. For example, the tone, they lose tone, and their tongue. We've talked about it several times. Basic procedures will keep that tongue in position and prevent the epiglottis from covering the glottic opening. We have two main ways to open an airway. We have the head tilt chin lift maneuver or the jaw thrust maneuver. Let's look at the head tilt chin lift. This will align the airway structures and provide a free airway passage. How are we going to do this? We're going to put one hand on the top of the head or the forehead area, and the other hand we're going to take our 3 fingers and we're going to put it in the center of the lower jaw. We're going to apply pressure to the forehead in a downward motion as we're lifting the chin. It's going to move the jaw forward, and we don't want the mouth to close. It'll just pull the jaw forward and the mouth will remain open. Here's a nice picture of it. See his or her hand positioning. The jaw thrust, we use this if we're worried about a spinal injury, right? We don't want to be tilting the head and lifting up on the jaw if we have a neck injury. We're going to keep the head, neck, and spine aligned. We're going to move this patient as one unit in a supine position. We're going to kneel at the top of the head. You're going to place your hands on each side of the lower jaw with 3 fingers at the angle or right below the ears. We're going to bring that lower jaw forward with our index fingers. We're going to push up the lower jaw. If we have to, we can retract the lower lip with your thumb to keep the mouth open. And we don't want to tilt or lift the head, right? We're not moving the head. We're just moving that jaw forward. Here's a nice picture. See how this provider has their hands positioned. And this is if we worried about spinal involvement, right? If we don't want to compromise the spine. Obstructed airways. If an airway that you just opened remains obstructed, we're going to have to consider a foreign body, right? There's something in there, possibly something in there. If we attempt to ventilate and reopen, the airway still fails, we're going to start our foreign body airway, right? Procedures, which would be the abdominal thrust on a conscious patient or CPR on an unconscious patient. Choking can be classified as severe or non-severe. Of course, in severe, the trachea is fully blocked and no air movement. And on the flip side, non-severe, it's partially blocked and there are some air is being exchanged. These people or patients will be coughing. And if you think back to your CPR class, we're going to encourage these guys or these patients to cough. Again, the conscious severely choking adult, which means total airway obstruction, we're going to use abdominal thrust. We're not going to go over that because we did it in CPR, but remember, if they do go unconscious, we're going to start CPR. And an infant that's choking or got a fully obstructed airway, we're going to use the back thrust, chest thrust maneuver, just like we talked about in CPR. If you can't wrap your arms around the adult patient, you're going to deliver thrust, position hands over the sternum. And again, if they become unconscious, we're going to start CPR. The only difference is before we get breast, we're going to look into airway. If we can see something, we're going to try to remove it, do a sweep. Let's talk about adjuncts for a second. Airway adjuncts. We manually open the airway, but an obstruction may resume when we release, right? When we do the head tilt chin left, and it opens the airway, but as soon as we let go of it, the airway closes again. This is where an airway adjunct can help maintain an open airway. Two common types. We have an oropharyngeal airway, which is referred to as an OPA, and I will be referring to that from here on out as an OPA. And a nasopharyngeal airway, which is an MPA. Again, I will be referred to in those as MPAs. So the whole main function of these two devices is to keep the tongue from blocking the airway when you lose muscle tone. Let's talk about the OPA. They are not to be used on patients that have a gag reflex. So that would be a contraindication. A contraindication means when you shouldn't use something or do something. So if they have a gag reflex and we insert this into their mouth, we can cause them to vomit and obstructing the airway even further, right? And if they can't tolerate an OPA, for example, even an unresponsive that has a gag reflex, we're going to switch and go to the NPA. We're going to open the airway manually before we add the adjunct. We're going to take care not to push the tongue into the pharynx using this device. And you're going to have your suction ready, right? Anytime we're dealing with airway, we're going to have suction, especially the OPAs, because if they start to vomit, we need to suction it. Again, if they start to gag, we're not going to advance any further. We're going to remove it and go to the NPA. We're going to maintain head position after adjunct is inserted and monitor the airway, right? This doesn't mean that the airway is completely open, so we still have to do our maneuvers, the head tilt chin or the jaw thrust when we're, managing the airway, but this will help hold it. Going to have the suction available in case we get fluids in the airway. If they regain consciousness and develop gag reflex, we're going to have to take this OPA out immediately. And you're going to use the infection control practice or maintaining, right? The minimal, you're going to have gloves, but anytime you're like suctioning, they recommend gloves, a mask, face shield. The OPA, or oropharyngeal airway, is a curved plastic device that we insert in the mouth. It has a flange at the top of it that will rest on the lips. That's how we know we've seated it proper. What it'll do is it moves the tongue forward and it curves back into the pharynx, so it keeps an open airway. They come in standard sizes ranging from adult to infant. A complete set should be carried. I actually recommend that you have two. An airway is not effective unless it has the correct size. And we're going to talk about sizing here in a minute. Here's a nice picture of the airways. You can see they're different colored for different sizes. However, I will tell you that some of them are all white. So you can have like 5, 6 different sizes, but they're all white. So we're going to measure from the corner of the mouth to the tip of the earlobe on the same side. Another way you can measure is from the center of the mouth to the lower jaw, the angle of the lower jaw. We're never going to use this device unless we've actually measured to make sure it's the right size. If the airway is too big, air will be directed to the stomach instead of the lungs. And if it's too small, it's going to push the tongue backwards instead of cradling it, moving it out of the way. Here's a nice picture of them measuring from the corner of the mouth to the earlobe. And here's the alternate method from the center of the mouth to the earlobe. How are we going to place this? Patient's going to be supine. We're going to do manual airway maneuvers to open the airway. We're going to open the mouth using our cross finger technique, which there will be a picture of that here in a minute. We're going to position the airway device with the tip pointing towards the roof of the mouth, or it'll be turned 180 degrees. We're going to insert the device along the roof of the mouth, usually about halfway. Here's a nice picture of that cross technique. Here's a picture of them inserting that airway. We're going to gently rotate 180 degrees so the tip is pointed down in the patient's pharynx. Position the patient, check the flange of the airway is seated proper against the lips, and we're going to monitor the patient closely. Now, the MPA is used when you have an intact gag reflex, or when the teeth is clenched, or there's some type of oral injury. Now, a contraindication can be a basilar skull fracture, epistaxis, which is a nosebleed, or nasal trauma. Nasal trauma. Now, with the basilar skull fracture, that's a fracture at the base of the skull. And the old theory is that we can actually advance this nasal airway into the fracture area and do damage to the brain. However, there's no evidence as of right now of that, and I know they're doing research, so this may change later on. Our nasopharyngeal airways, or MPAs, are going to be soft and flexible in the field rather than the hard plastic, because there are some that are clear plastic ones that you see in a hospital, but we want the soft and flexible ones. How are we going to insert it? We're going to measure it, right, from the tip of the nostril to the tip of the earlobe. We're going to lubricate the outside with a water-based lubricant, and if you don't have water-based lubricant, you can always use the patient's saliva. We're going to push the tip of the nose up and insert the airway. Keep the head in a neutral position. The bevel, we're going to be pointed towards the septum or the base. Here's a picture of them measuring it. And here they're lubing it up. And here they're inserting it. Insert it into the nostril. We usually use the right nostril. Advanced along the floor of the nasal pharynx. And the flange should rest firmly in the nostril. That's how we know it's seated right. All right. So we talked about the two basic adjuncts. Now let's talk about supraglottic airways, or you also hear these called BIAD, or blind insertion airway devices. These airways isolate the glottic opening by occupying the space in the larynx and hypopharynx, right? That's where they're seated, in that the lower part of the pharynx or right above the larynx. We use these when the basic maneuvers have failed, or if we need to maintain an airway over a long period of time. If we've got a long transport time or longer transport time, we're going to use these devices. And how we put these devices in depends on the manufacturer. I will tell you there are three main ones we see in the field. The main one right now is called an iGel. And then we'll also see the King LTSD or LTD. And there's a device that we don't see so much anymore, but we used to use all the time in the old days, called the combi tube. How are we going to put these in? We're going to prepare the patient. We're going to attempt those simple procedures first, and when they fail, then we're going to go to these. Position the head. We're going to pre-oxygenate the patient, which means we're going to give them a couple minutes of using the BVM while our partner is getting the equipment ready. We're going to pre-oxygenate, because putting these devices in may take a few seconds, so we want to make sure we get enough oxygen in their system. Prepare the team. We're going to discuss the roles and responsibility. Who's going to pre-oxygenate? Who's going to get the equipment ready? And have the suction ready. Who's going to assign? We're going to assign suction, assessment, and equipment duties. We're going to prepare the device. Size the device per the manufacturer. Most of them are weight-based. I will tell you that. We're going to make sure that we check our equipment before we insert it. For example, if it's got like a King Airway or the Combi's got inflatable balloons, We're going to make sure these balloons will inflate and hold air, and then we're going to take the air out before we insert it. We'll lube them up, and we'll insert them. And you have to do it per the manufacturer's instruction. Each one's a little different. If you're in my class, we do get hands-on experience with these, at least a couple of different ones. And of course, you're always going to have suction ready just in case you need it. Speaking of suction, that's our next topic. Uses gravity to clear the airway. This is putting the patient on their side in recumbent position, let gravity help us out, let the fluid drain from the mouth, hopefully. This is a fast compared to the alternate techniques. It can be used while you're preparing your devices. And we don't want to do this with suspected spinal injury or where there's only one single respirator. We use gravity. Always turn the patient's airway away from your body. You don't want that stuff on you, so you turn it away. Suction devices. They use vacuum devices to remove foreign material from the airway. A patient with fluid or secretion or they start gurgling sounds, they have to be suctioned immediately. Each suction unit will include a suction source, a collection container, tubing, and suction tip or catheters. Vehicle mounted or onboard suctioning. These are the big ones that we see in our ambulances. They create a suction using the engine manifold or electric power source. I think most of them are electric power source now. They have an electric motor. They must furnish an intake of at least 30 liters per minute and at the end of the collection tube. So they're going to have the capability of suctioning at least 30 liters per minute. And they must generate a vacuum of 300 millimeters of mercury when the tube is clamped. And that's how we test our suction units to see if they're working. We'll clamp it off, turn the suction on, and we want it to get to that 300 range within like 3 seconds. There are portable suction units. They can be air-powered, electric-powered, or manual. In today's EMS, a lot of them are electric-powered, but we still have the little yellow hand pump manual ones. And they must have to provide the same suction as an onboard unit, or they will not pass qualifications. Here's a picture of a mounted or an onboard suction unit. If you look at the top of it, you can see the device to measure how much millimeters of mercury we're getting. You see all the tubing, and there's the collection canister. So operating a suction device, it requires tubing, suction tips, suction catheters, collection canister, and a container of clean or sterile water. The most popular suction tip is a rigid pharyngeal tip, or we call them Yank-Howers or tonsil tips. It allows mouth and pharyngeal suctions with excellent control because it's a stiff device. It has a larger bore than most of the flexible catheters, and it is most successful using on unresponsive patients. The soft suction, or the suction catheters that are flexible, we call them soft or French suction catheters. They come in sizes identified by French number, which means the larger the number, the larger the diameter of the tube. Designed for suctioning when we can't get that rigid tip in. The collection containers should be non-breakable and easily removable, right? They are replaceable. They're disposable. We don't clean these out. We throw them away and put a new one in. We dispose it properly and then put a new one in. And we want some water in case we get a partial blockage of our tube. We can clear this by dipping it in water. Remember, infants are very sensitive to vagal stimulation. The vagal nerve runs in the back of the pharynx, and if we put too much pressure in that area, we can stimulate that, and it will cause their heart rate to drop. So we're going to minimize the suction time and take care to avoid this hypo or the lower part of the pharyngeal. We can use a bulb suction syringe in smaller children. It's very effective in cleaning the airway, especially in childbirth. We use this during childbirth, right? So those little blue bulb suction, we suction and we'll talk about that during the childbirth section. All right, suctioning techniques. We're always going to use our PPE, right? And like I said, they recommend gloves, eye protection, mask, and a face shield when we're suctioning. We're going to limit our suction to no longer than 10 seconds whenever possible. We're going to place the tip or the catheter where we want it to before we suction and suction on the way out. Most of these have a hole at the top, and you have to cover the hole to create the suction. So you'll stick your Yankauer or your tonsil tip in where you want to suction, put your finger on the hole, and suction on the way out for no more than 10 seconds. And they may activate the gag reflex, which will cause the patient to vomit if we're down in there and we activate the gag reflex. Here's a nice picture of their one positioning the patient's head, turning the patient's head, or entire body to their side. All right, keep an airway open, the definitive care. Sometimes, in order to keep an airway open, it exceeds the capability of what you can do as an EMT. So it's outside your scope, right? This will require that we need advanced life support or paramedic or advanced EMT for an endotracheal intubation. That's the ultimate airway in the field. However, if the hospital is closer than our nearest intercept, we may just manually control the airway and get them to the hospital. Special consideration, facial injuries, right? Bleeding, heads and faces bleed a lot. So they're very vascular, so they can bleed a lot. So they may require a lot of suctioning. With facial injuries, you may have to do an airway adjunct or an intercept and put an endotracheal tube in. Again, that's above your scope. That's an advanced EMT or paramedic level. Remember that suction units are not adequate for removing solid objects. If it's a completely obstructed airway, we're going to have to do the abdominal thrust, chest thrust, and finger sweep. Also remember if it is some larger objects, but we can always take off our tip or our catheter and use the suction tubing itself, which is a larger diameter. Dental appliances. Dentures should be left in place during these procedures. They help hold, will help create a better seal when we're BVMing or bagging them. Partial dentures may be dislodged. So if you have a loose denture or a partial denture, we're going to remove it. And that's what that next statement says. If the airway has a chance to become in danger, we're going to move or remove these dentures or partial dentures. All right, let's review just a little bit. Remember, the airway is a passage where the air enters and leaves the body during respiration or breathing. We can't survive without an open airway, or a patient can't. You'll hear the term over and over in EMS training. If you don't have an airway, you don't have a patient. It's a true story. So you're going to have a patent airway. When we're talking about airway adjuncts, we have two, the OPA and PA, and they'll help keep the airway open. Remember, suction may be necessary. It's used to remove fluids and solids from the airway before, during, and after any ventilation, or adjuncts, or supraglottic devices, or biads. Remember your PPE. At the minimum, it's gloves. But anytime we're dealing with the airway, they recommend a mask and gloves, eye protection, and face shield. Airway assessment's ongoing. Status can change over time very quickly, so we have to constantly be assessing the airway. Anytime we've got to manage an airway, we should start simple with just the maneuvers, and then progressively get more complicated if necessary. So we have to, do the head tilt chin lift and an adjunct, and eventually, if the adjuncts are failing or a long transport, we may go to a biad device like an eye gel. All right, that's it, folks. We'll see you on the next one.